I've got a really good friend joining us today with Miller & Company. His name is Dr. Don Arnold. Don, it's good to see you again.
It's good to be back.
We get to talk, but we never get to see each other.
That's true.
It was worth it today.
That's true.
The only part that wasn't worth it was walking in while it was 95 with heat index of 107.
Did you have your water?
There's a reason why I'm doing this, because
Excellent.
Don's asking as my doctor and physician, right? Because I didn't know we called it stone season.
It is definitely, we are in the heart of stone season.
Right?
Yes.
When you've got this kind of temperature. Now, here's the thing. It's making them the conditions, or they're coming out during this time. This is the time they're grown in your kidneys.
Correct. Right? All the above. So if you're prone to kidney stones, this is the time where you're going to have an attack if you don't do the necessary precautions.
You know what's interesting about this? At one point, and I told you this when we were talking on the phone yesterday, you were told, well, if you drink, football practice, you drink water, you're lightweight.
Right.
You're baling hay and you want a glass of water out of the water jug. And then it's like, no, what's wrong with you? What?
Right.
Right?
Right. Absolutely.
And those people, I know them now. And one described it, he says, I swear, I go in the bathroom and it sounds like I've got a BB gun on repeater charge hitting the back of the porcelain.
Absolutely.
That's
not good.
That scares me.
Yeah, that's not good. That's not good.
So how do you fight it? How do you get back? How do you keep from finding yourself in this position? Because here's the thing, the stupid things you do when you're 28, you'll pay for it when you're 58.
Sure. And
this is one of them.
Sure. I think the main thing is, just as you alluded to, is habits. What are your habits? When you're out and you're sweating, that's your body telling you it needs more water. It's using your water to cool you off. So there's nothing macho about passing out. And let me tell you, there's nothing macho about coming in with a kidney stone. No one's macho then.
I tell you what, it's the equivalent of males exploring the birth process.
I will tell you, women have told me it's on par.
Yeah,
for sure.
That's what I've heard.
And it's avoided. In our aspect, it's 100% avoidable. Just drink the water.
All right, now here's the thing. Water, and you said that word about 3 or 4 times.
Yes.
If you haven't paid attention, he's using the term water, not energy drinks.
Correct.
When I went into the statistics, because Roz Rice is here, she's in the back, and she says, if you got a minute, you should talk about the increase in kidney disease and kidney stones in younger people.
Yes.
I was not prepared for the numbers that I found.
Okay. Let's talk about it.
In 4 to 10% increase in pediatric kidney disease. And there's also a big, in 18 to 34, huge jump. Females, 45% jump. What do you attribute that to? Younger people. We're talking about people who are very young with kidney stones.
Sure. Well, let me ask you this. When you were in junior high or you were in high school, were energy drinks available?
No.
Exactly. It wasn't really available when I was there either. Now they're readily available, number one. Number two, we have this social pressure to exceed and be excellent all the time. And dare I say, energy drinks
look cool too.
They look cool, right. And energy drinks are approaching performance enhancing drugs, so to speak, right? All we had was caffeine, right? Now you have the energy drinks. Now you have the electrolyte drinks. Now you have people trying to get prescriptions they don't need.
All right, now I got to pick this one out. The electrolytes. Somebody's going, wait a second. I thought that's what I needed, so I didn't.
So unless you are losing athlete level electrolytes, there's nothing to replace. Your body is pretty good at it. Now, if you're a laborer who's outside and you're losing buckets and buckets of sweat, absolutely replace the electrolytes. If you're in the NBA or NFL, replace the electrolytes.
So you don't have to replace them. You put in the electrolytes on top of it, and they say, well, we'll store them in the kidneys.
That's right. So anything your body doesn't use, it's going to filter out. So all those crystals will filter out, and then we'll be seeing each other at 2 a.m.
It's interesting. A friend of mine who had a kidney stone, he decided to bring one to me.
Yeah. Have you seen it? What'd you think?
Well, I thought it was prehistoric. I thought
Egyptians were the first ones to identify.
If you blew it up to this size, it would look like the head of a mace. Did you see something in some kind of medieval?
Yeah, we call that the devil stone or jack stone. Yeah.
I mean, they really are. Yes. They look like an anti-personnel device.
Yes, they can be. They definitely can be.
So what's your advice to people like that? Besides, is there something more besides drink water?
Sure.
And also when it comes to this, because we keep talking about guys that might have it, because most women don't talk to me about their kidney stones.
Sure.
But the guys do, and they're like, no, I was in the bathroom for, 6-8 hours and it still is not out. And the doc's giving me this. I mean, I know some people who are really fighting this on a regular basis. What's your advice?
Sure.
Male and female.
Sure. Well, to your point, men outpace women with regards to incidence, but it's not by much. Women are actually gaining on this because of the things that you mentioned. But the advice is obviously to drink your water, limit salt, and limit meat. And when you drink water, put lemons in it or get lemon juice and add it to it. That helps.
I didn't see that one coming.
Yeah.
The salt, I probably should have thought of. It's crystalline in nature,
And when you eat salt, calcium's a little brother of salt. Wherever salt goes, calcium wants to go. So as your kidney's trying to get rid of salt, it takes calcium with it.
What are the symptoms here? That I assume we've got two sets of symptoms, male and female.
For kidney stones?
Yeah.
Actually, they present very similarly. Nausea, vomiting, extreme pain, fevers, chills. If you get really sick, you can have confusion.
It sounds like an infection, Don.
It can be, because most people ignore it. What do? Oh, I got a little bit of back pain. Let me take some Tylenol. Oh, let me lay down. Oh, let me get a heat pack. People forget your kidneys are a filter for poison. So what happens when that filter doesn't work?
All right. So here's a question for you, because I'm curious about this personally.
Sure.
Back pain to me goes from anywhere to where my crack starts to where my head.
Yeah.
Right? So where are we talking about back pain?
Yeah.
Well, I know this ain't my kidneys.
Sure.
Right? Get me in the neighborhood.
Sure. So if you reach behind your back and you can feel your ribs, where your ribs start is considered the flank. So right in that area. So anywhere from that area on downward, you can have pain.
A shooting pain?
Shooting pain. Mm-hmm.
And then the signs of an infection.
Yeah.
All right. Now, here's something else. As we mentioned, Dr. Don Arnold's joining us today. He's also the chief of surgery for SIH, a couple of locations, and this is a urologist, including where we're at. Aaron.
Yes. Yes, sir.
So I'm watching, and this had to be 30 years ago, maybe longer, Don.
Yeah.
And I'm watching WSIU TV, and they got one of these medical programs.
Okay.
And it's high-tech stuff, right? Robotic this and robotic that, right? And I think, I've thought about this a lot. I think calling it robotics is a misnomer.
Okay.
And the reason why is because I like you. I think when people say robotic surgery, that it takes the intense training and hand and mind of the doctor that makes those machines. Robots do their own thing.
Right.
It'd be better off if we called it a Waldo.
Okay.
It was a coin turned by Robert Heinlein. When I was a kid, I read all of his books, and a Waldo is something that you can have a hand. If I could take that hand and put it across the room, it would do
the work.
Right? That was what he envisioned.
Okay.
And that's what you use, because this sets here, this machine, these machines set here until you are ready to make it happen.
And we control it from beginning to end. It does nothing by itself. It is not autonomous.
And I think that's one of the things that we should talk about. That, that there's the hand and mind of the trained physician that has to come about. And the other thing that I think we take maybe for granted is by using these devices, the change in outcomes.
Yes. So the less I interfere with what you already have, the better your outcome is going to be. Meaning, when you look at surgery, the first surgery is open surgery, right? And this is from the 18th century. This is how it started. That's a drastic impact on you, right? So outcome is not going to be as great as if I can do the same surgery with a minimal impact. So we went from open surgery to laparoscopic surgery to hand-assisted laparoscopic surgery to now robotically assisted laparoscopic surgery. So we're able to very minimally invade the body to have very maximum outcomes. So let's use the example of a kidney surgery. We used to do open kidney surgery where you would have an incision, that went from the tip of your rib all the way down to your pelvis, and you'd be in the hospital for 2 weeks. That surgery would be 4 to 6 hours or longer. It wasn't uncommon to get blood transfusions. It wasn't uncommon to get massive infections. It wasn't uncommon to have hernias, be in massive pain and take narcotics. That's where we started. Now we can do the surgery an hour and a half, 2 hours. You're home in 48 hours with no narcotics. And people can barely tell you had an incision.
And I'll tell you what, the post-op, because I just had a friend of mine who had the hip replacement surgery, right?
It's amazing.
Was on the phone with, they cut him open.
Oh, there you go.
So he's basically bruised from his ankle to his shoulder.
Yep.
Right. His body has been traumatized. I've watched it. It's the only video I watched. I watched the hip replacement that I thought, well, I bet you he scored high in shop.
Yeah.
Because there's a saw out, right? I mean,
it's
and then they're rooting out the part of the femur. So the hip, and I'm like, whoa, man, I don't know, no. So I got a friend of mine, young, just went through this.
And then you take that and contrast that with the Mako, which is minimally invasive.
Right. And then the other thing that you and I haven't talked about, the nerve damage that goes on where you can feel like your skin's on fire for days afterwards.
Sure.
We're avoiding a host. Sure. And I really was really curious about this. Now, the big numbers say post-operative infection, really important. Mm-hmm. Open surgery, average recuperation, 16 days. Robotic, 7. Now,
depending on what you're talking
on the
about.
surgery.
Yes, sir.
And what I found interesting was from robotic to laparoscopic, we put those in one category to open. You've got, with open surgery, a 14 to 24% higher chance of an infection too.
Sure, because the first line of defense is your skin. So the bigger the incision, the less defense your body has, a higher chance of a bacteria getting through and causing a problem. Absolutely.
Yeah. I mean, I had a cousin who just went through surgery down Texas, laparoscopic, and a colon resection. And, once he does the things that he has to do, they'll let him out. He's already done. They just got to make sure everything's okay.
Absolutely.
And I really do think this is kind of interesting. I watched that stuff 30 years ago. And, that's what they do in the big city.
Right.
And I think metro medicine and the work that you've done over the years you've been at SIH of bringing metro medicine to Southern Illinois, which by any standard is rule.
Absolutely. By all standards.
Yeah. And then grandma doesn't have to go to Evansville.
Absolutely.
Or Kate.
Absolutely.
Or St. Louis.
So what I tell people is, if you want that option, you absolutely have it, because the best healthcare is a healthcare that you're comfortable with. But I tell people you don't have to go. But if you want to go, the option is there. SIH has done a very good job on recruiting specialty and subspecialty in all genres of medicine, with urology, surgical oncology, cardiothoracic surgery, colorectal surgery, vascular surgery, trauma surgery. So everybody who's trained in these big cities, there's someone that works here. So they bring all that knowledge and expertise with them when they come here to work.
As you being chief of surgery, what's your responsibilities when it comes to recruitment?
Is to make sure we keep going. Is to make sure we keep pushing the envelope. Is to make sure we have what we need here so people don't have to leave.
Or do you kidnap them, or how does that work exactly? Because here's one, look, I look at this as a cascade.
Yeah.
Kidney stones, metro, they don't do a lot of work in Bale and Haight, right? Or whatever the case.
Right.
We have higher incidence of kidney stones from Southern Illinois, correct?
Absolutely.
We have less reason for some people to come here because it's rural.
Sure.
When I talk to the people at the VA recruiting,
yes, sir,
to get doctors there, it's a task. They have a cultural deficit extra type of check that you're given because we're culturally deprived.
Sure.
So you found the person, they're talented, but that doesn't mean they know Da Vinci.
Sure.
That doesn't know that they know the other things that you want them to know as chief of surgery. So you have to recruit and educate.
Well, thankfully, a lot of this now is becoming commonplace in the residency. So when I was training, I wasn't introduced to Da Vinci till very end of my career in residency. So I did additional training and fellowship, where essentially it's an apprenticeship where I work under an expert for 2 years, and that's all we do. Now, because they've infiltrated into so much of the education, most people have that background when they come out.
Da Vinci say, hey, here's a free robot.
I wish.
They don't?
No, they don't.
I guess it's because they cost $3.2 million.
But what I do
There's a
to get
3.6.
people here is tell them that the winter is probably a lot softer than where they're from.
Oh, you got to sell it up.
That's how I got to sell it up.
The barbecue.
And also, what's very unique here that I enjoy is you feel like you're part of a community. There's people I operate on that I see in the community, and it feels good to see them as people, because I think sometimes we forget people have a like outside of my surgery for them. That's a whole person. You know, there's other people that care about this person. This person lived a life outside of me. And to see that and be reminded of that on a regular basis helps to show me the whole picture of this person as an individual and not just a procedure.
I don't think that's intrinsic to you, but I think you have it in greater portions than some other people have.
Right.
I mean, when you read some of the reviews of people that have had healthcare at your hands,
Yeah.
they like you, Don.
That's my mother. I give her all the praise and credit.
I'm kind of curious. When somebody's going to surgery and they see the machines, are they off-putting, or do people go, oh, wait, I got the best? I'm kind of curious about that.
I think it depends on how much research they've done ahead of time.
Because the internet can scare the living shit out of
I
you.
think if you've looked at it before, it looks familiar, so you feel comfortable. I think if the person, like you're saying, you have this idea in your head and then you see it and it's not like that, I think it can be off-putting. You know, thankfully, you know, YouTube is out there and people can go on there and kind of get an idea of what we're going to do. You know, we talk to people about it, but when you're in the office, I think sometimes a lot of that is lost because you're trying to get the information of what's going on.
And they're scared.
And you're scared and you take your time and you actually look at it. You know, but I think people know that everyone that works here, we're doing our level best to bring you the highest level of care that we're capable of doing. And my colleagues are very talented people.
What does that require of you, Don? In specifically self-discipline, what does it take to keep you doing this? Because as we record this, I'm not going to look at my watch, but I'm thinking we're around 6:30.
Yes, sir.
I mean, you got to have self-discipline because you were here at dawn 30.
Absolutely.
I know you were.
Absolutely.
I know that you take other jobs at other hospitals. You're working, you're driving.
I do.
That just doing what I did in the morning show took a little more self-discipline than I probably cared to.
Sure.
Kind of admit, but with you, you're way out of my league, my friend.
Well, I think it's all relative, right? And I think, you know, one of the things that I've learned, and I listen to a lot of, you know, like self-motivation or people that talk about success, like those kind of things.
So you're always working on yourself?
Absolutely. And one of the things they talk about is understanding your why, because that's the hard part. If you don't understand why you're getting up to do these things, everything else is irrelevant, because that's the hardest thing is, why are you getting up to do this job?
Oh, well, I guess now's a good time to ask.
And my why is I got into medicine genuinely to help people. I genuinely wanted to put them
Where
in a better
did you
place.
get captured in that? Because see, you and I both getting around the block, you sit in the room with a lot of people. I've conducted some 13,000 interviews just on News Talk. I didn't count the other 25 years, right? And here's the thing, there's some people that don't get it.
Correct. Well, I would have to say, I grew up in a very matriarchal family with regards to my mother, my aunt, and my grandmother. And one of the things impressed upon me was empathy. Not sympathy, but truly empathy, which is different.
Yep.
Is knowing how it feels to be somebody else. And being good at science and wanting to help people. You know, when I went to the Museum of Science and Industry for the first time as a kid, that was the spark. That was the first domino. So I knew I wanted to do something in science and I wanted to help people. So a physician, you know, when you're that young, that's just a concrete thing. The physician is the next step. But knowing how people feel and then having a skill set you've acquired that can help them to feel better is a feeling I can't even describe to you. Like I tell people, you know.
Also the why is kind of the how. Is that feedback.
It's a feedback loop,
but there's a payoff at the end.
Absolutely.
See, and that's I think that eludes some people.
Yeah, and the payoff is not financial. It's emotional.
It's hard to get from here to there.
It's an emotional payoff because I know what your future holds if I don't intervene. I can see it. And I know what it holds if I can do something to the best of my ability. And I can see that. And for me to give that to you makes me feel good as a person. And that's the payoff, is I feel good knowing I did everything I could do for you and we had a good outcome. Likewise, if I know what you need and I'm not the person to do it, I know who to go to and I can get you to that person. And I still feel good knowing I set you on a path to change your future. So that's why I do it. Now, does everyone do it for that reason? I can't speak to that. But that's my why, is to make your life better.
It's interesting because F. Buckminster Fuller used to talk about this. We were talking about before we started recording today. And he had an old saying that he looked at the time he had suffered a substantial emotional loss in his family. And he looked for a payoff where I can help the most people. I will be most effective when I help the most people, which makes sense with your schedule because you work your hind end off, and I know you do.
Well, you know, as the saying goes, to he much is given, much is expected. And I almost didn't do medicine at all. I was very grateful that certain things happened at certain times, which allowed me a way in. So I'm extremely grateful for the opportunity and the platform in which to have the skill set, because I almost didn't have it. So I guess it's my way of showing my gratefulness for the opportunity, because medicine saved my life, it saved my family. It allows me to provide, and it allows me to be fulfilled. And I don't know what I'd be doing if I didn't have it. So I'm just very grateful. And I guess that's my way of paying that back, is helping as many as I can while I can.
Applying
because
yourself.
At some point I won't be able to. That's just how it works.
Yep.
And I want to know at the end that I gave 1,000% of myself to this thing that I almost didn't have at all.
And you left your mark.
And and a lot of people don't have something they feel that passionate about. Most people see this, you know, as work or a business or a clock in, clock out. But for me, it's a living thing that I nurture every day within myself and in other people, in hopes that
as long as you stay away from the bean counters, you can keep doing that.
Exactly. Yeah.
Right? Because here's the thing.
That makes it difficult.
Yeah, if you suffer from idealism, not that I dislike CPAs, they have their place, but on the other hand, I'm having fun here and we're doing something really cool. Let me do my job.
Yeah,
right?
and also what people have to remember is you get what you pay for, you know, and you can't walk into Ralph Lauren paying Target prices.
Yep.
That's not how it works.
You get what you pay for.
Yeah.
I can't believe you set me up this way.
Yeah.
Because that's when I want to start off again with robotic surgery.
Yeah.
Things I didn't know.
Sure.
One, I didn't know, right? Because these are lot smaller tools than I can envision here, right?
Yeah.
Haptic feedback.
Yes, sir.
I did not know you could feel what you were doing.
Well, you can do that now. It's called a DV5. So for those that play video games, if you ever played a video game and the controller vibrates, that's available now. I was trained under doing it with your eyes. Without that, that's how I was trained.
Right.
So it's different. So what
that would explain that there's a difference in cost of $1.5 to $2.5 million for a Da
As
Vinci.
the console gets better.
One has haptic and one doesn't.
Correct. So I was trained, as well as other people were trained, is to see how the tissue responds to your force.
Right.
And that's how you can determine if you have enough force, too much force, or too little force.
I think color,
you know, stretch, the dynamics of it.
Yeah,
you know,
because you don't feel resistance
you
because
feel
it's an electric motor running all
you feel
that.
absolutely nothing. And what's weird is when you're trained, it feels very foreign. Then eventually you feel with your eyes. And that is the weirdest feeling in the world, to look at something and know exactly how much force you have.
Experience, right?
Yeah, it comes with experience.
All right, so how do we explain how small these are? How can we?
I would say probably for people who work on watches,
Mhm.
you know, those kind of instruments.
Really?
Yeah.
Ooh, that's even smaller than I did.
Yeah, because the camera's magnified and it's HD and it's 3D.
The other thing I didn't know was total cost of ownership for a Da Vinci for 5 years runs between $3.6 and $5 million.
Absolutely.
So even after you bought it,
That's just the beginning. So what I tell people is everybody thinks acquisition is the hard part. Even though it's hard to acquire, that's the easy part. The hard part is maintenance. That's where it's difficult.
oh, and you got to write a service guy.
Right. So it's like buying a house. You thought buying a house was hard. That's not the hard part. It may have been hard to do. That's not the hard part. The hard part's your maintenance.
Yeah, owning it.
You're owning it. Yeah.
Get up on the roof.
Yeah, get up on that roof. Get underneath in them pipes. Get in that crawl space.
Toilets out.
Yeah, that's the hard part.
True story.
So that's the hard part with robotics. So it's not buying the robot. It's, okay, now we have a robot. Now we have to have a program. Now we have to have standards of care. Now we have to have quality assurance.
Sterilization.
Now we have to have sterilization.
Plastic to wrap all the important parts with, changing it around.
And now we have to have standardization, right? Because you don't want variability in your workflow. So it's all these maintenance things. That's actually the hard part.
Do you have to train people when they come here?
Yes. So anyone that comes here, you have to have what's called proctoring. So that's where you're with an individual of like training that just makes sure that you're okay to proceed forward. Physicians that don't have experience that want to get training, they get trained by Da Vinci, and then they get a certificate saying that they're competent to do cases, and then they're proctored to do cases.
Here's another one for you.
Yeah.
And this to me is science fiction. And I
Okay.
watched the videos of this years ago, decades ago, and I'm so glad. And there's been some really big innovation in sonics. The Japanese it'll put you in a tank of water,
Yep.
locate that kidney stone,
Yeah.
send the sound through the water.
Yeah.
Nobody's cut open, and the stone
Absolutely.
goes away because your body's all
Absolutely.
water, right? Boom.
Yes, sir.
Just incredible stuff,
Yeah.
right? But what you're doing
Yeah.
is using water as a knife. And for the first time in Southern Illinois, May 1st, St. Joseph's Hospital, ablation. Ablation?
Yeah.
Is that right?
Yes, sir.
Now,
Yeah.
this is an incredible piece right here, right now, because anybody who's thought, I don't want a big sharp knife near my prostate.
Sure.
Is there any guys who've ever said, would you please put something sharp next to my, right?
Not willingly. No.
Never, ever happened.
No.
You don't have to have that problem anymore. You've
Right.
done this first, and this is this is brilliant.
Yeah. So SIH is the only organization that has this in the immediate area. We're the only ones. If you want to get this done, you're traveling at least an hour to 2 hours away. We're the only ones here locally doing it. Myself and Dr. Srinivas Rajamahanti, who's in Carbondale, is doing this.
Applications?
So it's really right now for enlarged prostate. They're looking at it for prostate cancer. It does not have an FDA approval for that yet, but they're looking at that. But right now it's for enlarged prostate. And I really think it's going to be the gold standard eventually. And it's going to replace the TURP, or the transurethral resection of the prostate. Once again, that's what we used to do. It used to be 2 hours long, blood transfusion, inpatient, catheter for 2 weeks, pain, sexual side effects, bladder perforation risk. Now this procedure takes 8 minutes. Catheter, can be 1 to 48 minutes to 72 hours.
2 hour operation to 8 minute operation. Now here's the other thing,
Outpatient.
because function and outcome. I mean, basically everything you and I talked about since I started, it's stone season, has been about outcome.
Yeah.
Now we've talked a lot about the process, but outcome. And this, what you're doing here. Now, if you've been water skiing and then behind a fat boat you fall, you know that it hurts. The water is suddenly very hard.
Yeah.
Right? So you've got that problem. Now, what I find interesting is ablation. I get that you can drive water so hard you can cut stone.
Yeah.
But in this, I didn't know before that heat was used before for ablation. So now you're using water with no heat.
Correct.
And so all these sexual malfunctions or lack of function, that there's this whole arena that happens just because you're using not hot water.
Sure. So let's look at the TURP. So that's a transurethral resection of the prostate. So when we do that, we have a scope that's in the urethra. We're looking at the prostate and we're using a hot loop to cut through it.
One of two cameras.
Yes. So the problem is, if this is your prostate, right, and I'm looking at it from this direction, I can't see how deep that goes, right? I have to use judgment, right, as I'm cutting. And everyone's made differently, right? And you can go too deep, get to the nerves or blood vessels. You can go not deep enough, have the tissue regrow too fast, right? All these things can happen. With the aquablation, we have an ultrasound probe that's in the rectum that's looking at all these structures. So I can see exactly where everything is. So then we use AI to do a primitive map of it, and then we go in and change that map. So I can control exactly how deep it goes. I control exactly how close it is to everything. And I can avoid things that I want to avoid every time perfectly, because I'm mapping it out myself.
This is the beginning of something big.
So when I saw this technology, I told SIH, I said, this is the future. This is going to be the standard of care. We need to get on this wave.
And not just about prostate either.
No, and not wait for the rest of the world and then catch up to it. I said, we need to get on this now, because this is where it's going. And we can get on this wave right now and ride this wave all the way through.
Guy you worked on May 1st, what's he say about it?
Everyone has loved it. I've done 4. Yes, sir. I've done 4. Dr. Raj either has done 4 or more. Everyone's catheter has been out the first day that we take it out. No one has been in retention afterwards. Everyone seems happy.
I want to put a number to this.
Yeah.
Because the issues with ED and other items, using ablation is a 85% improvement
because
for
we can see
retained
it.
sexual function.
Yeah.
And the way it was used to be done, maybe 20%
Correct.
retained sexual function.
Once again, outcomes.
Big numbers too.
Because we
And
can see
we're
it.
not shaving, we're not 4.6 here.
No.
We're talking 85% improvement in this. Whereas once upon a time, an 80% chance, there's 10 chances
Yeah.
you're not gonna like it.
Correct. And you have to have that in order to have your urinary function, where now we can preserve it.
All right, so now we kind of got off a little personal earlier, because I know you told me about grandma and everything.
Yeah,
Played a huge role in my
Absolutely.
life too, right?
absolutely.
But you've been doing this 20 years now, Don.
Yeah.
How's caring people? What is care? My Don Arnold math. Dr.
Sure.
Arnold is communication equals care.
Mhm.
That's my math that I
Sure.
assign to you.
Okay.
What do you think?
I
Close?
like it. Yeah, that's close.
Okay.
You know, I think part of that is also knowing where you're at and try to get you to where you want to be.
Are you talking about your skills?
No, I'm
Or
talking
are you talking about patient care?
I'm talking about inpatient care.
Okay.
Yeah, because I can communicate to you, but if I don't know where you're at or where you want to be, have I really cared for you?
I can see what I customarily think is the doctor will tell me what the outcome is, and I'll just have to go home alone.
Well, that's how we used to do it. You're right.
Yeah, pretty much.
Yeah. But now the conversation would be, okay, well, what's going on with you now? Where is it you want to be? This is what I can do for you.
But there's something else that you do well, Don,
Okay.
and it doesn't involve pills or scalpels.
I think it goes back to the empathy.
You take all that
Yeah.
skills capital, take that off. There's another thing you do
Yeah.
that and quite frankly, looking at the reviews people have given you, they see it too.
Yeah.
And that's care. That's
Yeah.
care. That care. It's not.
Yeah.
It's not where you want to be. It's
Yeah. Well, I would
Well,
use the word
empathy, I
empathy.
get.
Yeah.
Yeah.
Is knowing how you feel and communicating with you on that level and addressing how you're feeling. Right? Because the facts are the facts, the math is the math, the procedure is the procedure.
I've had doctors walk out the
Yeah.
door and still going, but
Yeah.
right, they're gone.
Yeah.
They're out there.
Yeah.
Hello.
Right. No. You know, and I'm gonna give you the time you need. Now, does that mean I run late? Quite often. But I give everyone the same amount of time.
Well, if you with your
Right.
patient load, that's got to be
Yeah.
that's got to be difficult. Time management.
Yeah, and if someone needs more, because not everyone says that they need more, I can just tell. So I'll ask an additional question or I'll probe a little bit more and let them.
Can you tell people fibbing to you,
Absolutely.
Yeah.
Yeah.
even when they're not checked up? That's the
right.
blood pressure.
Yeah, that's right. Yeah.
That's
That's one of the perks of
another
being an
skills.
empath.
Yeah,
Yeah.
a skill.
You know,
skill
and I
set.
tell them, I say, listen, I'm here to help you.
It's the eyes, isn't it?
Yeah, it's the eyes, it's the breathing rate, it's the heart rate.
Yeah.
It's the tone.
I go with the eyes and the tone.
The
Yeah.
tone, the speed.
Working all those times in interviews over
Yeah.
the phone, you
Yeah,
got to
you
listen
can hear
real
it.
deeper down
you
in
can
until
hear
you can hear it, and then people don't
Yeah.
like it when you know that.
Correct. Yeah, but I tell them, you know, I'm here to help you. So the more honest you are with me, the better care I can give to you.
University of Illinois, graduated
Yes, sir.
2006, 2005,
We'll go with that. Yeah, around there.
somewhere
Around there.
Around that.
Yeah,
You've watched medicine change.
I have.
I mean, you and I have been friends for a little over 12, 15
Yeah.
years. How has healthcare changed? Money, procedures. What is the most profound changes of healthcare that you've seen as an empath? You've seen its impact on other
Sure.
people. What about its impact on doctors? What
Sure.
about the community? What have you seen change in 20 years,
You know,
Don?
I think the main thing is the cost to get it done, which is, you know, and people deciding between their health and something else. That's a really tough conversation to have. You know, it's really
Well,
tough.
I'm just going to go ahead and tell. I'm going to go ahead and spit it out right now. It's diagnosed with a 4.4 centimeter dilation in my thoracic artery. Well, insurance covered part of it. Probably about $20,000, $30,000 I'll need to dig into.
Right.
I ain't paying nobody $20,000,
Sure.
$30,000. I'm not going to do it. I'd rather keep $20,000, $30,000. I know I'm not the only person to say this to you,
No,
Don,
no.
right? I'm not sounding like a
No.
complete lunatic. Everybody in
No.
their else's room is going, I can't believe
No.
you're doing this.
Yeah.
Because I want that money for Kate. I want that money to take care of her.
Sure.
So if I pop, it pops. I just
Right.
hope I'm petting my dog while it happens.
Right. Einstein said the same thing. He had a AAA.
Right?
Said, if this is God's will, it's God's will.
That's way up
Who
there.
might interfere?
Right? Now I'm gonna follow doctor's instructions and take statins and blood pressure
and do all stuff that you can't control.
Right.
Absolutely. And that's the hard conversation, is people telling me, yeah, I know I need this, but I have this too. And trying to bridge that gap, because obviously we want to be fiscally responsible, right? In healthcare, we just don't want to send healthcare through the roof, but we shouldn't make it so expensive that people can't get what they need either. And where is that balance? And where does the government come in? And where do institutions come in? And where do all these rich people come in that have all this dispensable income, to kind of help with these things? Because we are a community of people.
And we see a lot of people too chip in and help.
Yeah.
Southern Illinois getters. They get it.
Absolutely.
Yeah.
So that to me is the hardest thing I've seen change, is going from, oh, you need these labs, these imaging, I'll see you at this time, to, well, I can't afford this. Is there something different? Or I can't afford this now, I'll see you in 6 months, and hopefully it won't be a problem.
My number is a lot lower than $20,000-$30,000. Mine runs around $3,000. I figure I'm worth about $3,000. That's the way.
Yeah.
I'm worth an old GMC truck.
Right. Right. But you got to do that or fix your roof, right?
Yeah, right. Got to make a pick.
Yeah.
I fixed my roof.
Yeah.
How'd you know?
Yeah.
What do you see coming to healthcare in Southern Illinois the next 5 years, the next 10 years?
Well, I'm hoping that the recruitment is on par and it continues, which I think it will. I'm hoping to get even more talented people down here to put their stamp on what they're doing.
I think we're perfectly placed for it. I'm reading about how Illinois has more highways and all this interconnected.
Yeah.
And Missouri, Kentucky, Indiana, and I'm thinking we're perfectly. Yeah. If you build it, they will come.
And I'm hoping, that robotics and artificial intelligence continues to exponentially grow, to assist us, not do the work, but to assist us in doing the work to give people the outcomes that they're looking for. I don't think it'll happen in my lifetime, but at some point, for urologic cancer, we don't operate it on anymore. It's an inoculation, or it's nanobots that go in and eat the cancer that you get rid of.
Well, the guy who created the PSA test, protein-specific antigen test, wrote in the Journal of Urology, he wished he'd never invented that.
I read that, but then I noticed he never gave all the money back. Did you notice that?
No, I didn't.
Yeah, he never gave all the money back he made off of it.
Right.
So
he said he felt guilty for emasculating generations of men.
Yeah. So I think his heart was in a good place, but I think the motivation was misplaced. So let me tell you what I mean by that. I don't think there's anything wrong with getting a PSA and telling a man he has prostate cancer. I think that's the right thing to do. Where we went wrong as urologists is thinking all prostate cancer was the same.
Oh.
And the energy should be in the prostate cancer that almost never kills you, the prostate cancer that almost always will kill you, and in the prostate cancer that's in the middle.
Are there four or seven varieties?
Well, there's different numbers we use, but those are the 3 lanes.
Okay.
So for men that have cancer that's almost never going to kill you, keep an eye on those guys.
And when I was reading this, one of the things he helped is you don't understand how incredibly slow these cancers grow.
Sometimes.
With the exception of, as you just
correct.
Right.
So those guys, you watch. Funny story, when I was in residency, we were just sifting this out. So towards the end of my residency, there was a gentleman who had Gleason 3+3 minimal cancer, meaning he wasn't going to die from it. Mm-hmm. And my attending wanted to do surgery. I said, respectfully, I'm not going to scrub your case. He said, why not? I said, because I don't believe that this man needs surgery based on what we know. I think that we can watch him. He said, are you serious? I said, yeah. I said, no disrespect to you. I'll find someone else to scrub this case with you, but I can't do it in good conscience. And he's not going to die of his cancer.
That's exactly right. And that's this guy in his article, he wrote it. The guy who didn't send the money back that's not going to be what kills them. He's 78 years old.
And he's right in that. So we should put energy into watching those guys. Likewise, if there's someone who has cancer that's aggressive that we know is going to be a problem, then we should offer treatment and be aggressive.
But we got those PSA tests and it had 42 or whatever it was, and they went in with a weed whacker. It emasculated men. So there's kind of a...
Because we believed at the time we were doing good. We didn't know we weren't doing any good. But when that data came out, that's where we as urologists have to be good stewards and say, okay, we need to rethink how we're looking at men and recategorize them. Because if you get a PSA and nobody, right, and say it's not important. If I take his stance, it's not important, it doesn't matter, you're not going to die of it.
You would lose a valuable diagnostic tool.
And we know in African Americans and Latinos, they have more aggressive cancer by the time it's diagnosed. So that population would be dying sooner, faster from a preventable disease that has a 95% cure rate when found early, which is what was happening prior to PSA. We have that data.
Yeah.
That's what was happening. So that's why I say he needed to have a more nuanced approach and say, let's focus on the people that need care and treatment. You know, the people with a family history, the people that are at higher risk, the people that have a higher grade of prostate cancer. Let's focus our attention there and treat those people and leave everyone else alone. That would have been a better answer, in my opinion.
I think you and I could write an article for the Journal of Urology.
You think someone would read it?
I think actually by the time I was done writing it, it would be. Yeah. I'd use you with all the facts in it.
Yeah, absolutely.
Add a little to it. This is my guest, Dr. Don Arnold. He's also my friend. That's why he put up with me so long and so many different things I did wrong during this interview. Don, it's always a privilege.
It's been a great time.
I mean that too.
It's been a great time. It's my honor to be here.
And my friends that you helped,
yes, sir.
They want me to say thank you too.
Absolutely. Well, tell them I'm very grateful that they gave me the opportunity because they didn't have to see me. So I'm appreciative for that opportunity.
Chief of Surgery, Urologist, SIH, Dr. Don Arnold. Miller and Company, special edition with my friend, Dr. Don Arnold. And if you need to see him and you got the symptoms, come and see him, right? People don't want to talk about it, but not want to talk about stuff will kill you. And Tom Miller, Miller and Company. If you got questions, ask at integritypointmedia.com for your email. Thanks.